cardiac arrest. Now, let me ask this question in the beginning. What do you mean by cardiac arrest? Anyone? What do you mean? Yes? Any student? Anyone? What is cardiac
Sir,
arrest?
sir,
Mhm.
sir, it is the sudden loss of blood flow to the heart, so the heart will stop and the patient will unconsciousness, and there will be no central pulse.
Okay, good.
And
So
ECG finding there will be like
mhm.
no waves showing like a straight
Okay.
line.
Now, he mentioned some important things there. He said the heart stops functioning, there is no central pulse, and the patient is unconscious. Followed by, if you do electrocardiogram, then there will be a flat line. There will be no ECG activity. Okay. So most of the points he has mentioned are correct, but I like to add a bit there. Cardiac arrest means definitely heart has stopped functioning. There's no doubt about it. Arrest means heart has stopped functioning. When heart is not working, there is no pulse. So cardiac arrest is diagnosed by two important points. If the person who has fallen onto the ground, or if the person is unconscious, and when you palpate the pulse in that person, and if you cannot find any pulse, this is called cardiac arrest, and treat this patient as cardiac arrest patient. Okay, these are the two important points, because yes, you don't have ECG all the time. For example, if that thing can happen in the mall, for example, inside the shopping mall, in the street outside, okay, in the dorm, for example, in your own home or house, there are no ECG machines there, so you cannot do ECG at that time. Then how to diagnose cardiac arrest? By these two things. One, person is not responding. When you call the person by the name, person is not responding, means person is in unconscious state with no palpation of the pulse. This is known as cardiac arrest. So let's talk about it. See here, abrupt cessation of the cardiac pump function, which may be reversible but will lead to death in the absence of prompt intervention, is known as cardiac arrest. So here there is a sudden and complete loss of the cardiac output due to asystole, due to ventricular tachycardia or fibrillation, or loss of mechanical cardiac contraction. And it is manifested in two important ways. One, unresponsiveness of the patient, and second is lack of the central pulse. If we start resuscitation earlier, this condition is reversible. But after some time, if there is a permanent brain damage has occurred already, then what's the use of cardiac arrest even after doing, isn't it? The persons will be vegetative. So please mute yourself. Now see there, what are the clinical features and how to recognize a person who is in cardiac arrest? Cardiac arrest is a clinical diagnosis, definitely. Okay, something has caused it, So we have to diagnose this clinical condition first, and then what is the cause? Any patient who is unconscious and who doesn't have a major pulse is in cardiac arrest. This is the most important practical point you need to take from this class, so that you don't delay your management. Cardiac arrest has to be dealt immediately. There's no time to wait. And if I know these 2 points, I'll start my resuscitation right there. I don't need to do any other investigation. That is the meaning. The time taken to check for pulse or other sign of circulation should not exceed 10 seconds. We don't have time to spend there. Okay, just 10 minutes. Sorry, just 10-second time is there, not minute. Minute is longer there. Okay, just 10 second. Quickly, pulse has to be checked. And which pulse you check now? Which pulse? Yes, which pulse?
Carotid pulse. Carotid pulse.
Exactly. Central pulse means always carotid pulse at this moment. Okay, not the radial pulse, not the brachial one. It is carotid one. and any student can palpate carotid pulse very easily at this time. There are certain other clinical features like color of the patient, pupillary size or response. Okay, all these, there is no real time to check these at this moment. They can be checked later on. You always have time later on. Okay, but these will waste the time. That is the point, and they do not contribute to the diagnosis either. Note that some respiratory effort like gasping may persist for several minutes after the onset of cardiac arrest. Patient may have gasping breathing, gasping respiration. The normal respiratory rate in adult is 16 to 18 per minute. Gasping means just 1 to 2 or 2 to 3 per minute, less than 5 definitely. Occasionally, an arrest may present as a grand mal fit of shorter duration because of the cerebral hypoxia. So these are the different, clinical features of cardiac arrest. But the two most important one, on consciousness or unresponsive patient, and then loss of the central pulse. Let's move on. Now, what are the causes? What are the etiology of cardiac arrest? Look at these four important causes. Ventricular fibrillation, also known as VF, pulseless ventricular tachycardia or VTAC, it is known as VTAC, which is pulseless, asystole, okay, and pulseless electrical activity. Now, ventricular fibrillation is the most lethal among them because in no time the patient can die right in front of you. The heart is no more functioning after VF. If we do not defibrillate it, we may lose the patient. And it is diagnosed only by ECG. There's no other way. Pulseless ventricular tachycardia is also diagnosed by ECG. In this condition, VTAC is present and it is not associated with any pulse. So we manage them a bit similar way. Asystole means heart is not, beating at all. There's a flat line in the ECG, absolutely flat line. A straight line is visible on the ECG. That is asystole. Quick resuscitation is started in all these three things. And then pulseless electrical activity. It's a very interesting type of mechanism where, okay, heart is beating, heart is contracting, but there is no pulse. Means there is certain restriction, okay, to the cardiac output. So we'll talk about what are the causes of pulseless electrical activity. Let's start with ventricular fibrillation and pulseless ventricular tachycardia. These are most common and most easily treatable cardiac arrest, okay, rhythm. VF produces rapid, ineffective, uncoordinated movement of the ventricle, which therefore produce no pulse. So here, the ventricles are fibrillating actually. Fibrillation means it is not coordinated type of contraction. Okay, different muscle fibers are contracting in a different way. There is no coordination at all. So it is very ineffective type of contraction. So it cannot produce any cardiac output. And if there is no cardiac output, there is no pulse. The ECG shows chaotic, bizarre, and irregular ventricular complex. Now, I'm sure you still remember those ECG which we have discussed regarding the ventricular fibrillation. It is just like a scribble, okay, which is done by the child. So if I want to draw here, it will be like this. Okay, this type of wave is seen in ventricular fibrillation. Now, see there, ventricular tachycardia can cause cardiac arrest if the ventricular rate is so rapid that effective mechanical contraction and relaxation cannot occur, or if it occurs in the presence of severe left ventricular impairment. Now, tachycardia is a faster heart rate. We all know that more than 100. Okay, is ventricular tachycardia or simple tachycardia. So, if it is coming from the ventricle side, we call it ventricular tachycardia. VT or VTAC is the commonly used term. Any type of severe tachycardia, remember there is no diastolic, phase. A diastolic phase is very, very decreased. As a result of that, there is severe dysfunction occur. So VTAC can also kill the patient in no time, especially if it is associated with no cardiac output. Now, look at this, ECGs. We can remember, we have discussed them before also. This is VF and this is VTAC. One is regular. This is quite regular. This is ventricular fibrillation. There is no cardiac output or no pulse, in this condition. Where in this condition, there may be pulse or there may not be pulse. If there is no pulse, we call it pulseless ventricular tachycardia. It is almost similar to VF because we have to resuscitate quite quickly. Now, ventricular tachycardia may degenerate into ventricular fibrillation, and defibrillation is the effective treatment here. Defibrillation. So defibrillation, okay, restore the cardiac output in more than 80% of the patient if delivered immediately. So defibrillators should be available in all the hospitals, in all the centers, okay, and people know how to use it. Chances of successful outcome after defibrillation fall by around 10% with each minute's delay, and by more if basic life support is not given. You don't know how to resuscitate, that is called basic life support. You don't know how to give cardiac compression. You have no idea about it, and you are so nervous that you have not even started it. By the time this patient is taken to the hospital, even defibrillation may not work because it is very late now. So this is a very, very important practical point I'm discussing with you now. In our family, who knows, any person can suffer from cardiac arrest, especially if we have history of ischemic heart disease which runs in the family. Anybody can have this. So immediately start resuscitation, that is chest compression. Do not worry about mouth to mouth breathing. The concept of mouth to mouth breathing is slowly disappearing these days. But the most important point is cardiac compression or chest compression. I'll talk about that slowly in the subsequent slide. Start that and quickly transfer the patient to the medical center, the nearby medical center, which is quite near to your home. Take the patient there and then start advanced cardiac life support inside the hospital. This is the way if you want to make that patient survive. When cardiac arrest occurs outside the hospital, death is inevitable unless a defibrillator can be brought promptly to the patient. That's why ventricular fibrillation is the most serious type of, cardiac arrhythmia. It can kill the patient in no time, and the treatment is defibrillation. Now, asystole. Let's talk about it. Asystole occurs when there is no electrical activity within the ventricle. Okay, the ECG shows a flat line or a straight line. There is a failure of the conducting tissue or massive ventricular damage, which is seen in myocardial infarction that can result in asystole. So the most common cause of all these different types of cardiac arrhythmia is myocardial infarction these days. Myocardial infarction or MI. Cardiac massage, see there, cardiac massage or blow to the chest can sometimes restore the cardiac activity, although an artificial pacemaker may be needed to prevent further attack. Now, this is another important type of, practical point for us. Sometimes we need to, give a big thump on the chest, you know, make a fist and hit strongly on the heart area, on the precordial area. So that can simply, start the cardiac rhythm in case of asystole. Okay, if that is not successful, then after that you have to start cardiac compression. So if you're lucky, if the patient is lucky, that simply is enough. Those type of things have happened. And after we take the patient to the hospital, pacemaker may be necessary to prevent the further attack. Now look at this ECG here. This is called asystole. A proper medical term has to be given for this, okay? And this is one of the ECG question. If you remember, we have already asked this in your previous exam. Okay, this is known as asystole. And in many of the time when ventricular fibrillation settles, it has already killed the patient, remember that. So when the heart has completely stopped functioning, ultimately every type of arrhythmia will turn into asystole like this. So in many center, before declaring the death, they go for ECG, and ECG should show this type of line. Then only you can declare. But after you gain experience, you don't need these things. Okay, you can directly examine the patient, examine the brain stem reflexes, uh, quickly auscultate the patient, and you can declare the death. Now, the important point from this topic are pulseless electrical activity. What is this? See here. It occurs when there is no effective cardiac output despite the presence of organized electrical activity. Now, heart is functioning, heart is working here, heart is beating, okay, but there is no effective cardiac output. In other words, there is no effective pulse. It is caused by reversible conditions like this. Okay, these are known as H, okay, and T's. See there, hypovolemia, hypothermia, hyper or hypokalemia, hypoxia. Okay, this is metabolic acidosis or any other acidotic condition, tension pneumothorax, cardiac or pericardial tamponade, toxic substances, some of the overdose of the drug which can depress the heart, and thromboembolic or mechanical obstruction. So these are the reversible condition which can result in pulseless electrical activity. So in this situation, one of the very important point regarding the management is we need to reverse this condition. Then only heart will start producing effective cardiac output again. Only resuscitation, only doing chest compression or giving breathing to the patient may not help. Okay, so a proper diagnosis is really necessary here. It carries an extremely poor prognosis is not if not detected in time. So see this now. So these are the pulseless electrical activity causes. There are 6 H's and 6 T's, which is easier for you to remember if we remember this way. Hyperkalemia, okay, even hypokalemia, hypoxia, hypothermia, hydrogen ion excess, which is acidosis. They have made this acidosis also start with H so that it is easier for you. Hypovolemia and hypoglycemia. Okay, heart cannot function properly. And 6T's, cardiac tamponade, tension pneumothorax, pulmonary embolism. Okay, it's a type of thrombosis, which is causing myocardial infarction, toxins, and trauma. So all of these start with T. So try to remember this important one. Now let me ask you one question here. What is cardiac tamponade and how it causes pulseless electrical activity? Anybody?
Sir,
So it is a accumulation of fluid or blood in pericardial cavity with in higher rate, and when there is a accumulation of fluid in pericardial cavity, so it will prevent the diastolic phase.
Good, very good. So he's absolutely correct there. Remember, tamponade means pressure effect. So it is caused by the fluid which is collected there under pressure. That means acute type of collection over a shorter period of time, like bleeding. Bleeding after trauma is one of the commonest cause. That's why in case of road traffic accident, In case of chest injury, this pericardial or cardiac tamponade is very, very common there. And we should be able to diagnose it. Do you know how to diagnose pericardial tamponade? What are the clinical features? Anyone? What happens to the JVP in case of
Sir,
cardiac tamponade?
sir,
Like a triad, sir. Increase
sir,
GVP, decrease cardiac output, and muffle heart sounds.
Okay, good. These are the important points he has mentioned. Yes, yes. Anyone else can answer here? Yes, I'm listening.
sir, this same tried muffled heart sound, raised GBP, and bradycardia.
Yes, or hypotension. Okay, yes, you're right. Hypotension, then muffled heart sound, and raised JVP. Sometimes it is known as Beck's triad. So this is one of the very important clinical examination finding of a cardiac tamponade. Muffled heart sound is very easy to understand because there is collection of fluid around the heart. So, heart sounds are distant or muffled, isn't it? And raised JVP, because of the similar type of mechanism. Okay, there is a compression. And then hypotension because of decreased cardiac output. In the beginning, there is a problem with diastolic filling, but later on, there is problem in the ventricular contraction as well. So this is a pericardial tamponade. Okay, other things are not that difficult to understand. Now, what is the management of cardiac arrest? How we proceed further? As a medical student or as a doctor, what should we do? This is known as the chain of survival. A victim of cardiac arrest is most likely to survive if all links in the chain are strong. That is, if the arrest is witnessed by someone, then only the patient can be revived. Then only the patient can be, taken to the hospital, the nearby medical center. Otherwise, the patient may die there without even the notice of another person. If help is called immediately, okay, you alone cannot do much. So you need help. Okay, so shout for help. Basic life support is administered by a trained individual. Okay, there has to be a trained individual. Means somebody should know how to give basic life support. The emergency medical services respond promptly. You have called for the help, and you have asked that person to call the ambulance in time or those medical people in time, and they have responded promptly. Then only the patient can be survived. Otherwise, you have called for the ambulance and ambulance came after 1 hour, patient is already dead. Defibrillation is achieved within a few minutes. This is a very important, way of therapy in case of ventricular fibrillation. So this is not a chain of survival. Everything has to be there. Then only the patient has high chance of survival. Otherwise, patient will die. Now, see there? This is the chain of survival. So early access, we should call for the medical help. Early CPR, it has to be started immediately. And this early CPR is important to buy time. Now, the basic, you know, uh, role of this CPR is, let me explain right now to you. Remember, these days, what is the concept? Breathing is not very important one, because whatever blood is flowing in this patient's body, a bit of oxygen is already there in the blood. So even if the patient doesn't take new oxygen or fresh oxygen, it doesn't affect much. But that oxygenated blood should be going to the brain and should be flowing into the heart. Heart has failed to function. That's why it is called cardiac arrest. So we pump this heart, okay? We pump this heart, or we make this heart pump again by compressing the chest, so that blood will start going into the brain and into the heart once again. So this is the most important early management you can do from your side till you take the patient to the hospital. So this is clearly to buy time. Early defibrillation to start or restart the heart if it is a case of ventricular fibrillation. Okay, very important management. And then early advanced cardiac life support to stabilize the patient with the help of drugs, okay, and advanced type of therapy. Now, with this, let's talk about what is the concept of basic life support. What do you mean by this? Basic life support encompasses the maneuver that attempt to maintain a low level of circulation until more definitive treatment with advanced life support can be given in the medical center. So this is done right there at the site of scene, at the site of the problem. It should be started from there. Management of the collapsed patient requires prompt assessment and restoration of the airway, maintenance of breathing using rescue breathing or mouth to mouth breathing, and maintenance of the circulation using chest compression with the aim of maintaining the circulation until more definitive treatment with advanced life support can be administered. Now, clearly, three things are written here. If you pay attention, one is assessment of the patient. Very quick assessment. Only 10-second time is there with you for the assessment. Okay, just that much time. You don't have enough time there. Second, maintain the airway. Sometimes the tongue may fall backward and the tongue is obstructing the airway. So quickly maintain the airway by maintaining certain position. Second, mouth to mouth breathing can be given, but these days the American Heart Association have advised for another thing. Before this mouth to mouth breathing, you start chest compression. That is more important than mouth to mouth breathing according to them. And I already given you the reason. According to them, a bit of oxygen is already there in the blood. If you press that blood towards the brain or into the heart, there is a higher chance of survival than giving mouth to mouth breathing. Or you may be distracted by giving mouth to mouth breathing. A better thing is if two people are there, then mouth to mouth breathing can also be given side by side, and uh, you know a good effective type of cardiac compression also can be given. That's why we need help. One person cannot do everything. Now let's look at this algorithm, then everything is so easier for you. See this, the first thing is check responsiveness of the patient. That means shake the patient and shout. I call the patient by his name. Hey, can you listen to me? Okay, and we shake the patient. If there is no response, then we know patient is already unconscious. This is the first thing. Second, open the airway by doing this maneuver. This is known as head tilt, chin lift, and jaw thrust maneuver. But many of the cases, head tilt and chin lift will be enough. Okay. Jaw thrust maneuver is important in case of cervical spine injury. In that case, head tilt and chin lift may be dangerous, especially the head tilt. What is the danger if I do head tilt maneuver in cervical spine fracture? What is the danger? Yes.
It may it may compress the spinal cord at C3, 4, 5 level and may paralyze the diaphragm. Then
Exactly.
breathing will be compromised.
Exactly. So remember, if it is a case of trauma or not. In case of trauma, you do not know whether cervical spine is injured or not. So do not go for head tilt maneuver. But in some other medical condition, for example, inside the home, if a person is collapsed, this is not a case of trauma now. So you can safely go for head tilt, chin lift, and jaw thrust maneuver. This is to open the airway. If tongue is fallen backward by doing this thing, a tongue will come back in its original or normal position. After that, check breathing. Look, listen, and feel. Look whether the patient is breathing or not. You can simply take two of your finger in front of the nose of the patient and feel whether the patient is breathing or not. You can look for the rising of the chest or sometimes rising of the abdomen also. And if you have a stethoscope right there with you, you can listen for the breath sound. If breathing is there, put the patient in recovery position. If the patient is breathing, remember, there is less chance of, you know, uh, cardiac arrest. Means the oxygenation will not allow easy arrest to happen. Now, two effective breath can be given to the patient. This is known as mouth-to-mouth breathing. Then assess again for the signs of circulation. You have 10 seconds only with you. Means examine for the quick pulse. Okay. Put your hand to palpate for the carotid pulse or femoral pulse. Carotids are more commonly palpable. Now, continue the rescue breathing and check circulation every minute if circulation is present. But if circulation is absent, means no pulse is palpable, or if you have a stethoscope, you can quickly listen for the heart sound also. If there is no heart sound, then start compressing the chest. It is compressed at 100, time per minute. 100 time per minute. Or if you can maintain, you can have a ratio of 15 compression to 2 breath. Okay, 15 compression to 2 breath. If you have two persons there, then then this is the easily coordinated thing. If one person is there, then also it can be done. I will compress the chest for 15 times and I'll quickly give two mouth to mouth breathing, and then again I start compressing the chest. Like that we can do. But remember, these all things are done to buy time till the patient is taken to the hospital. These are not the permanent thing. So shout for help. Okay, ask for help. Ask someone to call for the ambulance and the medical people there, and take the patient as soon as possible to the medical center. This is known as basic life support. So this is American Heart Association adult chain of survival. Immediate recognition of cardiac arrest and activation of the emergency response system is necessary. It's call for emergency response system. Early CPR with an emphasis on chest compression. Rather than mouth-to-mouth breathing, emphasis must be given on chest compression. Rapid defibrillation, which is not possible outside the hospital. That's why early transfer is necessary. Effective advanced life support in the hospital and integrated post-cardiac arrest care. So all of these are necessary if the patient has to survive without any complication. Okay, see there, it is given by this different symbol. This is a call for the help. In the United States, you have seen in the different movie, it's 911, isn't it? They call 911. That means they are calling for the emergency help. In different countries, the telephone code number may be different. So in every country, it is available. Actually, we can call for the help. This is CPR or chest compression. Okay, defibrillation, right? This is the early transfer, and this is the care in the hospital. So everything has to be done. Now, this is a simplified adult basic life support. Make sure the patient is unresponsive first. Okay, if there is no breathing or only gasping, then you start resuscitation. Okay, meanwhile, activate the emergency response. If you can call on your own, do it. If you cannot, ask someone to do it. It's a very, very important one, because you cannot do this all the time there. You need to quickly transfer the patient to the hospital. Get defibrillator as quickly as possible. If patient is having VF, that is the only treatment which can treat the patient. CPR, and then transfer the patient to the hospital. One important point regarding CPR is push hard and push fast. Push hard, push fast. There is no rhythm which is necessary if you do not know it. Though we say 100 times per minute, but all people are not medical person, and they cannot really do that in that situation. Everybody is nervous at that time, especially if something, if this has happened with our one family member. Though we are doctors or medical person, we will be very nervous. We cannot do anything. Actually, we are frozen during that time. So forget about all this rate. Just push hard and push fast there, and try to transfer the patient to the hospital. That is the best thing you can do to save the life of that patient. Okay, and You will be quite surprised to see the result. Why this is helping the patient? The answer is very simple. Whatever blood is inside the heart, you are helping that blood to flow towards the brain so that there is no brain death. And some amount of blood will also flow into the coronary artery. So heart is also receiving whatever oxygen is present in that blood. This is the best thing you can do in this moment. So these are the key changes, okay, uh, uh, from the 2005 basic life support guideline. Let's quickly go through them. Immediate recognition of the arrest should be done. And only two things are there: unresponsiveness of the patient and absence of normal breathing, or sometimes there may be gasping breathing, okay? But main thing is there is no pulse. Look, listen, and feel thing is removed from the basic life support algorithm because this may consume time. Rather than that, they have encouraged chest compression CPR only. Push hard and push fast. That is the new modification these days. So sequence is changed. CAB is used rather than ABC. Airway breathing circulation was used, okay, before. These days, C means compression is used even before the airway. Okay, the reason I've already told you. And then continue it till the spontaneous circulation resumes, or till you have taken the patient to the hospital and everything is followed in the hospital later. Now see there, we're talking about this A, B, and C. These days, the American Heart Association have changed the sequence of resuscitation from ABC to CAB. Now, C means chest compression is started as soon as possible. Push hard and push fast on the center of victim's chest. Any person can do that. The person should not be a medical person. Okay, so this has to be taught even to the family member, according to me. All family members should know if something happens to our family member, what should they do. So if you have some free time, if you remember about these things, then teach all other family member how to do that. It's very easy. Maintenance of the airway comes after that, and breathing comes later on. So C, A, and B. These days we follow this pattern. Now, what is advanced life support? What do you mean by that? Have a look here. Advanced life support aims to restore the normal cardiac rhythm by defibrillation when the cause of cardiac arrest is due to tachyarrhythmia, or to restore cardiac output by correcting other reversible causes of the cardiac arrest. Like asystole is just simply go for a cardiac compression, okay, by thumping the chest and give certain medicines. Okay, all of these comes under advanced life support. ALS can also involve administration of intravenous drug to support the circulation and endotracheal intubation to ventilate the lungs, which may not be possible outside the center or outside the hospital. So that's why it is known as advanced life support. See there? Let's move on. Now, all of you, please focus on this algorithm. This is very important one. So whenever the cardiac arrest occurs, we give a precordial thump, okay, and sometimes it just work. It brings back the cardiac contractility to normal. If it doesn't, then follow the BLS algorithm. BLS algorithm, all those which we have discussed before. Attach defibrillator or monitor as soon as possible, and look for the ECG, a type of ECG, what is present there. That is called assessment of the rhythm. At the same time, you have to check the pulse. All of these hardly takes less than 10 seconds. If there is presence of VF or VT, then defibrillate the patient Okay, 3 times as necessary. Sometimes defibrillation just one time may be enough. If it is not enough, repeat it up to 3 times. Okay, then CPR is given within 1 minute time. Okay, or for 1 minute. Then assess the rhythm again. So this is the way. If this is a case of non-VF or VT, then you don't need to defibrillate. You just start CPR, cardiopulmonary resuscitation, for about 3 minutes. Okay, 1 minute immediately after defibrillation. See there, which is already described here. During CPR, correct the reversible causes, if not already, like check the electrode or paddle positions and contact, attempt or verify airway and oxygenation or intravenous access, and give adrenaline or epinephrine, okay, 1 milligram every 3 minutes. So these are the different way. This epinephrine dose is also, uh, written in the form of 1 to 1000 dilution or 10,000 dilution, like that. Okay. Consider the use of antiarrhythmic drug. Consider the use of atropine. Atropine increases the heart rate. We all know that. It is one of the important drug which is used there. Or consider using sodium bicarbonate, that is called buffer, because this is a state of metabolic acidosis, and that acidosis is causing depression of the cardiac contractility. So giving sodium bicarbonate really helps the patient. So these are the other things you should do during CPR. So one person cannot do all these things, remember? So we need multiple persons during the resuscitation. There are potentially reversible causes for this, cardiac arrest, which we have already discussed before. Okay, those are all these H and T's. Okay, hypoxia, hypovolemia, hyper or hypokalemia, metabolic acidosis, hypothermia, tension pneumothorax, cardiac tamponade, some toxic effect, thromboembolism, this is pulmonary thromboembolism, or obstruction. Now, what are those drugs which we give in case of advanced life support? Which drugs are commonly used? Important question which may be asked to you in different exam. The best route for administration of the drug is via a central vein, but central vein may not be possible in all the patient, so it can be given through the peripheral IV route. Give a 20 ml bolus of 9.9% saline and elevate the limb for 10 to 20 seconds to aid entry to the circulation after you give the medicine. Because we want that medicine to reach as quickly as possible to the heart. This is the process to do that. Push the medicine. You give the medicine first to the vein and push that medicine with this 0.9% 20 ml bolus. If venous access is not possible, and so many of the time, this is the problem, because the person is in shock, all the veins are collapsed, and we may not be able to find the vein. So what is the option for us? Then during that time, some of these drugs like epinephrine or adrenaline, atropine, and lidocaine, they can be given through endotracheal tube. Okay? They can be given through the tracheal tube or endotracheal tube at twice the standard IV dose. And sometimes we can give a bit of normal saline after that. And this medicine will go into the lung. Remember, the lung has large surface area and lots of capillaries. So the medicine can be easily absorbed from that area and it may help. But this is always the second step if the venous access is not possible. If venous access is there, then IV drugs should be given. Do not give sodium bicarbonate, calcium salt, or amiodarone via the tracheal route. They can do extensive damage there. Do not attempt intracardiac injection. Like sometimes you have seen in the movie, isn't it? In the movie, they show anything. The surgeon or the doctor just draw a bit of medicine in the syringe with a big needle, and he suddenly hit on the anterior part of the heart, and the needle will directly go into the ventricles or something like that. But this is only in the movie. We do not usually give intracardiac injection. Remember that. It can have some lethal complication and rarely reach their intended site also. Don't think if I give directly in the heart, it will act faster. Nothing like that. The best way is push into the vein and flush the vein, with a normal saline so that it quickly goes towards the heart because of good venous return. Small amounts, about 50 ml of 8.4% solution of sodium bicarbonate can be given to the patient with severe acidosis, that is arterial pH less than 7.1. Now tell me, why acidosis occurs in case of cardiac arrest? Why? What is the reason?
Sir, when there is cardiac arrest, there will be peripheral hypoperfusion, and anaerobic respiration will be there. As a result of that, the lactic acidosis will be formed.
Very good, excellent answer. So, okay, I'm sure many other students also know this explanation is absolutely correct. Because of the cardiac arrest, there is no cardiac output. So there is no peripheral perfusion. There is no aerobic type of respiration going on. During that time, anaerobic respiration will take over, and this is a severe case of metabolic acidosis. The treatment of metabolic acidosis, one type of treatment, of course, is giving sodium bicarbonate. Look at the pH; it is so less than 7.2 pH is incompatible with life. Okay, we have studied that before. So you don't even wait for 7.1. You can give it right there when the pH is around 7.2. Without giving sodium bicarbonate, it will, for example, inhibit the contraction of the heart. So even if you have done very good resuscitation, the heart function may not come back to the normal in the presence of acidosis. That's why this type of treatment is necessary.